We wanted to do a special focus on sepsis in the simulation lab over the next few months. Prior to running cases in our lab, we want to lay out some basic foundations for the emergency department staff. The sickest patients in the emergency department, those that are in septic shock, it has been shown to have a decrease in mortality if they are treated aggressively with fluids and early antibiotics. We are in a unique position in the emergency department as we are in the front line and the first medical professionals that these patients encounter. If their early sepsis syndrome is caught by us, they have the best chance for survival. Our aggressive interventions can either be left individually or by an institutional bundled care measure. The benefit of institutional protocols is that it limits case-by-case variability. Bundled care measures also have shown to decrease mortality. Some basic historical context. This aggressive management was brought to national attention by Emmanuel Rivers in 2001 with his early goal-directed therapy algorithm. In his study, his aggressive algorithm resulted in a mortality reduction as shown below. In the early goal-directed therapy versus standard care, the mortality rate went from 37.1%, which was with the early goal-directed therapy, versus 49.7% in the standard care group. Now, his algorithm was pretty aggressive and invasive. Basically, these were patients with severe sepsis or those that are in septic shock. The definitions for that were lactic acid greater than 4, or patients that remained hypotensive after 30 cc's per kilogram over a 30-minute period of time. Now keep in mind, 30-minute period of time, that's a lot of fluid. So for many rivers, this was a 6-hour protocol, and all of these patients had a central line and arterial catheter. The main focus points were a CVP between 8 and 12, a mean arterial pressure greater than 65, an SVO2 greater than 70%, hematocrit, if they didn't get that measure, hematocrit over 30%. So a lot of patients were getting blood transfusions, a fair amount of fluids, inotropic agents. And the whole concept was that he wanted to optimize oxygen delivery to tissues based on these metrics. Now, the standard definitions that we are all familiar with, and now CMS completely changed the definitions, but it's important to kind of go over what our foundational knowledge is sepsis is SIRS, which is either a temperature greater than 100.4 or under 96.8, 38 Celsius or 36 Celsius if you prefer that, a heart rate greater than 90, a respiratory rate greater than 20, or a white blood cell count greater than 12, under 4, or with 10% bands. Sepsis is 2 of these plus a presumed infection, and severe sepsis is sepsis with organ hypoperfusion. Now, organ hypoperfusion is a lactic acid greater or equal to 4, or a systolic blood pressure under 90, or a systolic blood pressure that is under 40 millimeters of mercury from what the normal is. And severe sepsis is, or septic shock is severe sepsis with hypotension despite adequate fluid resuscitation. Now, over the last 3 years, there has been a trio of studies that have come out: Arise, Promise, and Process. There's a lot of information and numbers on the slide. I just want you to just kind of take a look and skim this. It just I found these diagrams to be very interesting. Without going into too much detail, I mean, these articles are free online for you to be able to get. You go through PubMed and be able to access them. Basically, they demonstrate that in patients who are recognized early as having sepsis and treated with IV fluids and antibiotics, that Manny Rivers' early goal-directed therapy did not really provide any significant improvement over patients that were treated with usual care. And if you could take a look at Process, Promise, Arise, you could see, what the early goal-directed therapy patients received in terms of volume, fluid, central line access versus, what the usual care was. Now, one thing to also notice is, standard of care from what Manny Rivers had in 2001 was likely a lot different than standard of care that they received in these studies. Just in the Promise study alone, patients received on average of 2 liters of fluid. 46% of them had a central line, arterial lines, pressors, central line access, even blood transfusion, just not to the exact extent of the early goal-directed therapy. So now we're going to also go into another big change that recently happened. Along with these 3 studies, CMS also changed the definitions for severe sepsis and septic shock. Now, CMS uses pretty much the same definition for sepsis, which is basically SIRS criteria plus the presumed infection. But now septic shock or severe sepsis is now SIRS criteria 2 plus an infection, plus some sort of organ dysfunction variable. Now this includes a systolic blood pressure under 90, a MAP under 70, a decrease of 40 from baseline, a creatinine greater than 2, so acute renal failure, a decreased urine output, increase in bilirubin greater than 2, platelets under 100,000, an INR greater than 1.5, altered mental status, or a lactic greater than 2. Now that's something really important to notice, is that the lactic acid for severe sepsis in the past was 4 or greater, but now the lactic acid is 2 or greater. So you could just imagine that the denominator for patients that are now in severe sepsis has greatly expanded. Now, if you have baseline renal failure or are on Coumadin, these aspects are exempt from the severe sepsis diagnosis. However, if you have a patient who has a heart rate of 95, a white blood cell count of 13,000, a urinary tract infection, and a lactic acid of 2.1, that is now considered to be severe sepsis. I really like this slide. Basically, this goes over what our new expectations are in regards to treatment plans and algorithms. So if you look at the bottom, this is hours. So there's a 3-hour bundle and there's a 6-hour bundle. And this is severe sepsis and this is septic shock. Now, keep in mind that we've been over the severe sepsis diagnosis. Septic shock is patients that have a lactic acid greater than 4 or a systolic blood pressure under 90. So the first thing you want to do is you want to measure lactic acid for any patient with severe sepsis, obtain blood cultures before starting on antibiotics. Now keep in mind that if there's a 45-minute delay in order to get blood cultures, just give the antibiotics and explain your reasoning of giving antibiotics before. And administer broad spectrum antibiotics. Early antibiotics have demonstrated to decrease mortality in patients with septic shock. Haven't really been shown any evidence for severe sepsis, and the treatment plan or CMS core measure is for severe sepsis and septic shock. Now, septic shock, if the person's hypotensive or has a lactic acid greater than 4, at that point you are expected to give 30 cc's per kilogram over the first 3 hours. Now, when you're admitting these patients, the 6-hour bundle is most likely going to be taking care upstairs in the hospital team. Having said that, if there's a patient in the emergency department under your care that has been there for 6 to 8 hours, you are expected to do the 6-hour bundle. So it's important to be aware of this. For a patient with severe sepsis, if their lactic acid is greater than 2, it needs to be redrawn at the 6-hour mark. So please communicate with the hospitalist to make sure this is performed. Now, if the person remains hypotensive, despite adequate fluid resuscitation, please make sure that you give them vasopressors. And the other thing is you have to document a response to your treatment. That means you either measure the CVP, measure the SVO2, do a bedside cardiovascular ultrasound, do a dynamic assessment of fluid responsiveness, either a passive leg raise or fluid challenge. Now, of those 4 things, you have to do 2 of them. So a CVP, a SVO2, an ultrasound, or some sort of fluid responsive challenge. Or you have to do a focus exam, which includes vital signs, cardiopulmonary, capillary refill, pulse, skin findings, and a remeasurement of the lactic acid. These are significant changes. Time and again, early aggressive management and antibiotic administration has been demonstrated to decrease mortality in shock patients. We are uniquely situated as we are in the front line of the hospital and the first team that these patients see when they arrive. Sometimes the diagnosis of sepsis can be very difficult to make. We recommend following these measures, but to follow your clinical instincts more. If you do not agree with giving 30 cc's per kilogram or have a patient that fits the severe sepsis criteria, please do document your reasoning. This will come across as a failure of CMS compliance, but it's important to do what you feel is right for the patient. Now, other things I do want to touch on that are not part of the CMS requirements or not detailed in the CMS requirements are an important aspect of antibiotics. It's important to start broad spectrum antibiotics for a source of infection, but if you can target a source or a clear source of infection, such as cellulitis or a patient coming in with a urinary tract infection that has known susceptibilities, please do that instead. Source control. Practice good source control. If you have an infected PICC line or an intravascular device that needs to come out, plan to have it removed. With pressors, if you've adequately resuscitated a patient and they're still hypotensive, don't wait for the 6 hour mark. Start the central line, start the vasopressors. The first line is really norepinephrine. Steroids, not the best evidence for this, but consider 200 milligrams of hydrocortisone IV for patients in refractory hypotension after fluids and vasopressors, the thought being possible adrenal insufficiency. And of course, if their hemoglobin is under 7, please do consider a blood transfusion. The core measures and surviving sepsis guidelines have been placed as evidence that demonstrates improved mortality with shock patients. While they have also included severe sepsis patients and redefined that term and greatly enlarged the denominator of who fits into that criteria, we have an obligation to know these definitions, know these treatment algorithms, and follow such aggressive management as we see fit. Should we, in our clinical judgment, feel that the definition does not fit our patient or treatment not be appropriate, we should document our reasoning. While this may come across as a failure in CMS compliance, ultimately our primary responsibility is to our patients. Thank you for listening to this lecture. We look forward to practicing these terms, these definitions, and these practice patterns, as well as these algorithms in the simulation lab in the coming months.